Hello, everyone. Thank you for joining us on day one of National Primary Care Week. My name is Malika Severwal. I'm the chair of the Community and Public Health Action Committee for AMSA. Today, we will be discussing maternal and child health with Dr. Ramas. Following her presentation, we will have a Q&A session. At that time, please type in any questions that you have in the chat box, and Dr. Ramas will answer them. Dr. Marie Elizabeth Ramas is part of the American Academy of Family Physicians. She practices family medicine with obstetrics in Nashua, New Hampshire. She provides comprehensive family medicine services in both inpatient and outpatient settings for all ages, and also advocates on behalf of family physicians and patients nationwide to inspire positive change in the U.S. healthcare system. In addition to providing clinical care, Dr. Ramas has been active with the AAFP on the national and state level. She currently serves on the American Academy of Family Physicians Board of Directors and has represented the minority voice as a minority delegate to the AAFP National Council on Special Constituencies and the AAFP Congress of Delegates. A 2003 graduate from Washington University, Dr. Ramas earned her medical degree from the Case Western Reserve University Medical School in 2008. She completed residency in family medicine at the Lone Star Family Medicine Program in Conroe, Texas in 2011. And in addition, she has completed multiple certifications in advanced life support in obstetrics, pediatric cardiovascular disease, and trauma. So without further ado, here is Dr. Ramas.
Hi, everybody. Thanks again for that great introduction, and thank you for allowing me to present on maternal-child health disparities. Hopefully we can learn a little bit about what disparities are and how we as primary care or future primary care providers are able to impact the patients that we serve. So as Ashley said, I work at a community health center currently. And I do practice of full spectrum family medicine in the Boston area, delivering babies and taking care of everyone from birth to death. And it's been a real pleasure. So go ahead and type in your questions. And if you have any real pressing questions that you want to ask during the presentation, please don't hesitate to chime in. And here we go. So today, like I said, we're going to be talking about maternal-child health disparities and breaking down the barriers. And and I don't have any disclosures or conflict of interest as far as this is concerned. So the goals of the presentation today are to define disparities and how they relate to health outcomes, define factors that contribute to poor health equity, and identify significant areas of health disparities in maternal and child health. And as related to that, we're going to discuss interventions that may reduce barriers to quality health care. And then to put the icing on the cake, we're going to talk about the role of family physicians and other primary care physicians in the improvement of maternal-child health disparities, and hopefully have a robust conversation as far as how we can contribute there. So before we start getting into the stats, it's important to talk about what maternal-child disparities are. And there's a group, the Association of State and Territorial Health Officials, that issued a brief. But first, this group, per its mission and its goals, it's a national nonprofit organization representing public health agencies in the United States, the U.S. territories, and Washington, D.C. And over 100,000 public health professionals are employed in these agencies. Now, the ASTHO members, the chief health officials of these jurisdictions, formulate and influence sound public health policy, and they ensure excellence in state-based public health practice. ASTHO's primary function, which is important for us in this conversation, is to track, evaluate, and advise members on the impact of the formation and of public and private health policy, which affects them, and to provide guidance and technical assistance onto improving the nation's health. And so this organization has the latest brief in 2012. I was able to get a lot of good information that I'll be sharing with you today. And the other important thing as far as this organization is it's really devoted to the reduction of maternal and infant health disparities. Now, some might question, why is public health important in medicine? And what is the, can you guys hear me? I see we've got a couple of questions there. Can't hear me. Are you able to hear me now? Okay. Okay. Great. Awesome. Thanks for the voice. So what I was saying is that this organization is devoted to the reduction of maternal and infant health disparities. And some may question, what is the importance or the correlation between public health concerns and medical concerns? And there are a couple of caveats with that. So public health costs money, and we understand, particularly as a family doctor myself, I understand that my patients are part of a social context, and there are often barriers that that preclude my patients to be able to get the access to care and the health care that they need. But also, it costs a lot of money for the country. Per the Centers for Disease Control, medical costs linked to obesity, for example, were estimated to be $147 billion in 2008, and I'm sure that this has climbed over the last several years. And in 2010, the Centers for Disease Control made note that 86% of all healthcare spending were for people with one or more chronic medical conditions. And so clearly there's a correlation between our chronic healthcare and the context in which our patients are in. So before we talk about health care disparities, we need to understand what those terms mean. And you can imagine that there's a plethora of data and works, discussions around what health equity and what disparities are. For today, I really liked the definition provided by Paula Braveman and Laura Gottlieb in 2014 in their essay regarding health equity and reducing disparities. And their definition of health equity is social justice in health, meaning that no one is denied the possibility to be healthy for belonging to a group that's historically, economically, and socially disadvantaged. And I put emphasis on possibility. Now, in our country, unfortunately, we have socially disadvantaged populations that may have the idea or even may have the view from an outsider perspective to have access. But it's been shown time and time again that access to any care does not equate to the achievement of health. And so I really like in this definition how the authors took it one step further and described health equity as the possibility of being healthy regardless of your background. Now, taking that just another step further, what are health disparities then? And again, Braveman and Gottlieb, they described health disparities as the metric the metrics we use to measure progress toward achieving health equity. And so in our day and age where we are actively as cohorts of scientists, physicians, start looking for objective terms of attaining equity, these healthcare disparities are very concrete ways that we can look and see whether we are making measurable changes to reduce the gap. And so another way of discussing these disparities is through the concept of determinants of health. And social determinants of health I think has become really in vogue now, but I think there's sometimes confusion in what that truly means. And so I really like this illustration that you see on the right here, where you're able to see that as individuals, we live within a sphere that is encompassed by our social, economic, cultural, environmental conditions. And that's the overarching umbrella or foundation, rather, that then gives us the space to discuss how our society is able to be managed. And so examples such as food, especially when we're talking about obesity in children, food deserts, education, which is directly related to healthcare outcomes, knowing that folks that have a decrease or have a lower educational status tend to have worsened healthcare outcome and worsened access. We talk about work environment and whether that means paid family leave, or whether that means being able to breastfeed and to pump and to supply nutrients for a woman's newborn child. Taking time away as a parent if your child is sick, that plays a huge role in one's access to health and well-being. And then you go further in looking at social and community networks, and clearly there are discrepancies between different communities within within the U.S. and their access to services that are needed for well-being. And I mentioned before, having access to food that is healthy is a problem in the United States and a contributor to speaking about obesity, which also can affect maternal care. And all of that leads to what an individual is able to attain as far as choices and lifestyle factors. And so, as you can see, we live in a complex weave and a web of interrelated systems that is organic and that is vibrant. So socioeconomic factors definitely affect healthcare outcomes for the reasons that we talked about. And there was a sentinel study in 2006 by the Institute of Medicine that was really one of the integral points in healthcare where they were able to demonstrate that there were, in fact, disparities, and more prevalently, ethnic disparities when it comes to healthcare. And so I made a note of infant preventive services and primary language as examples. And so within this IOM report in 2006, it was noted that infants with parents whose primary language were not English were 50% less likely to receive recommended preventive services as infants whose parents had a primary language of English. And so the question is why? And there are multiple factors that were discussed within this report, but one being is that for one reason or another, whether it was health literacy and the ability for the provider or clinician to discuss appropriately preventive care, or if because of that added barrier, the clinician just did not think of offering preventive services because of the additional barrier that they have. But regardless, definitely having language as a barrier certainly plays a role in one's ability to get adequate health care. Now, in my setting, in the Boston area, I work in a federally qualified health center, and we take care of a large refugee population, but we also take care of a large immigrant population. And so what that translates to on my end as a boot-on-the-ground family doctor is that graciously we have interpreters, but every visit takes that much longer in order to complete. So a visit that would take 10 minutes maybe in my primary language would take maybe 20 or 30 minutes to complete because of the language barrier. And I'm sure you know, as medical students with, you guys are starting to get exposure to all of the changes in the requirements of primary care physicians when it comes to documenting electronic health records, trying to get payments from insurance companies. All of this bureaucracy definitely weighs on each encounter that a primary care physician faces on a day-to-day basis, and that might lean a provider or a clinician to skip out on some of those preventive care topics just out of sheer time. So that's something to keep in mind. The other thing that was interesting in the 2012 Institute of Medicine report was that there were 83,000 preventive deaths yearly due to racial or ethnic disparities. 83,000. Now, this isn't strictly on a maternal fetal basis, but I think that this speaks loudly in terms of why it is important to address social factors in a primary care setting, because in the long run, we're going to be saving, not unnecessarily spending dollars, but then being able to redistribute those dollars for vital services that we know communities need. So this is a busy slide, and some of you may have seen this already, but when speaking about determinants of health, one of the biggest topics is infant mortality when it comes to maternal child care. And when you compare the United States to the rest of developed countries, this is one place that we do not want to be on top. And the United States has consistently been the #1 country, developed country in the world with highest infant mortality, to the ranks of 3 times more when compared to Finland. There are several thoughts as to why that is. The United States is also, if not the only, one of the few countries, developed countries in the world that does not have a universal health care system. And I'm certain, and studies have definitely supported this concept, that that's definitely a contributor as to why we have such disparate results when it comes to infant mortality. So what does this mean in the United States? And this is where I think it's even more important. So in the United States, if you take that and extrapolate it against race, there's a huge discrepancy that is reproducible over the years between blacks and non-blacks. To non-Latino blacks, where we have a 2.4 higher mortality rate as far as infants are concerned than their white or their Latino counterparts. Now you'll see that there's Hispanic there. Hispanic really isn't a proper term, although we use it in our vital statistics, but it's more Latino. Hispanic is people that are of Spanish origin from Spain, as opposed to Latinos who are of Latino descent, Central American, Mexican, which is usually what we're talking about in our context. So you'll hear me say Latino as opposed to Hispanic. Just know that this is interchangeable. So again, so the thought as far as why the infant mortality rate is so much higher in the Black population as opposed to non-Black population, the thought is obviously multifactorial. Some of that may include generally Blacks have late prenatal care or poor prenatal care compared to their counterparts, non-Black counterparts. And there's also an inherent increased risk of preterm labor in people of African descent, as well as later treatment of preeclampsia and gestational diabetes in Blacks. And that obviously increases risk to the infant or fetus in utero. But the main cause of infant mortality is because of low birth weight, which we can see is also disproportionately weighed on those of Black descent. And so you can see again something that's really interesting here in this graph, which is this graph is from the Brookings Institute, but was more so from the Centers of Disease Control. And this is looking at, let me take a look at this question here. Great, thank you, Stephanie. So should medical schools encourage students to learn common languages in their areas of practice? So California medical schools encourage their future students to have background in Spanish before entering med school. That's a good question. I think that, especially as a primary care provider, and when you're going into medicine, medicine is it's a personal experience, and we go into medical school, most people do, because they want to help people. I think that having a background in Spanish, particularly in the United States, it definitely would not hurt you. It would help, I think, as far as work is concerned, to be able to connect with your patients in that way. You know, as an aside, you know, anthropologic studies have shown that when you're able to speak in someone's maternal language, that instantly creates a bond and a level of trust that, not to say that it's not achievable, but it definitely, again, reduces a barrier. As far as it being a requirement, I hesitate to say that it should be a requirement before entering medical school, because you know, when we're looking at how our physicians represent the cultures and the communities that we serve, Stephanie, that may put some students in a disadvantage compared to others, and we certainly do not want to disadvantage. Now, there have been some medical schools that offer immersion programs and study abroad programs while in medicine, and I think that we're going to see that as our country starts to look more towards primary care, especially, that those kind of opportunities and experiences for medical students and residents are going to be valued at a higher level than we see today, or are able to accommodate for today. Hopefully that answered your question, Stephanie. Keep the questions coming. So birth weight. So we see in between 1970 and 2010, again, very consistent low birth weight, which is defined as less than 2,500 grams or less than 5 pounds thereabouts, particularly in whites. But I want you guys to take a look at the bottom 3 lines too. So the bottom 3 lines you would expect that if in this conversation that people of Latino origin would also have a discrepancy. But for some reason, time and time again, when it comes to healthcare outcomes, we see what's called the Hispanic Paradox. And hopefully we change that nomenclature, but what it really says is that we really don't understand why, even though most people of Latino descent origin do have a lower socioeconomic background, for some reason their healthcare outcomes are not as stark when compared to African Americans. So we're not quite sure why that is, but it's definitely been consistent, particularly in relation to maternal fetal health, child health, and infant health. So maternal mortality. So the World Health Organization defines maternal mortality as death while pregnant or within 42 days of termination of pregnancy, and that's mostly for developing countries. What's interesting is that if you extrapolate that definition for developed countries within the first year after termination of pregnancy, then we start to be able to see nuances of discrepancies between countries that are developed. Another thing that we look at as far as maternal mortality is, what are the causes? And by far the largest cause of maternal mortality is preeclampsia and untreated hemorrhage in women who have delivered. So that's one of the reasons why the World Health Organization and ACOG and other organizations internationally have pushed treatment of hemorrhage and being able to bring life-saving measures for moms. So when we look at maternal mortality in the United States compared to other developed countries, again, this is not someplace where I would feel happy being number one, but the U.S. is the only developed country that has had more maternal deaths per 100,000 live births in the world. And so you can see down in the lower right-hand corner there that over the years there has been a decreased trending, and albeit there's more numbers, but still in the United States we increased more than doubled the amount of maternal deaths in a 23-year range. And so again, not something we want to toot our horns at, especially with the amount of money that we spend on healthcare. Now, what does this mean as far as race is concerned? Again, you guys guessed it. Again, there's a higher risk of mortality for those who have lower education status, who have lower income, and those who are Black. And so the most discrepancy are those who are Black, poor, and with lower education in the United States. And once again, here's just another graphic showing that the U.S. is the only developed country with a rise in maternal mortality, even when you compare it to other developed countries. So, it's quite disturbing to be able to see that. This is a busy slide, but I wanted you guys to have access to this because I think it gives a great visual as far as maternal-child disparities in the U.S. So, I'm not going to belabor most of these. We went over them already. But I think it's interesting. In the middle there on the left, 32.9% of U.S. cesarean rate in 2009, and we're at an all-time high following a 13 consecutive year rise. And so when you compare actually the cesarean rate from even the 1980s compared to now, it's more than doubled. And some of that, the thought is because of litigation. And then again, just on top of that, 12.7. So that's the deaths per 100,000 live births in the U.S. That's 3 times higher, as high as the government's Healthy People 2010 target. And so in 2010, one of the goals was to reduce maternal and infant mortality, as well as reducing the rate of low birth weight babies. And despite the increased technology and paperwork that we've had to do and litigation that we've had to do, it's still, we haven't reached our marks. And we now, even for the Healthy People 2020, we're not projected to be able to meet that goal. So as far as prenatal care and breastfeeding is concerned, if you look on the left side here, so for prenatal care, there was a really great opinion given by the American College of Obstetricians and Gynecologists, ACOG, in 2014 that reviewed disparities in prenatal care services. And one of the things, again, that was noted, which is a little bit different from what we've been talking about, is the concept of geographic location and how this also relates to the access to prenatal care. And so it's been shown that when you compare rural versus urban patients, that definitely rural patients, although they make up about 20% of the population, they take up about 70% of the costs in general for healthcare. One, because most of the time in a rural setting, people have less income. There's also less access to primary care, and in particular with obstetric care, we've noticed that if there is not an obstetric care provider in a rural county, then the rate of home births increase that are not safe. The rate of maternal and fetal mortality increases, as well as the rate of emergency room deliveries, which is not a great place to deliver a baby. Personally speaking, before I lived in Nashua, New Hampshire, I just moved this summer from a remote rural town in the border of California and Oregon, and I was one of 2 family physicians in the southern part of the county that delivered OB care to about 20,000 people geographically. And the closest tertiary center that had a NICU or an intensive care unit for babies was an hour away. Closest academic center was 3.5 hours away. But I can tell you that even though we delivered maybe about 150 deliveries a year, what we did though was created a safe net for one of the largest counties of California. So definitely rural versus urban, although the needs are different, still there are discrepancies as far as access are concerned. Another interesting disparity to just point out is breastfeeding. And so African Americans have the lowest breastfeeding rate, interestingly enough. And when we talk about breastfeeding, you know, there's, especially now, there's all this media that's coming out as far as the positives and the attributes that children, babies gain for their lifetime if they are breastfed. And the World Health Organization actually recommends that women breastfeed for at least 12 months and for ideally 24 months, which is very different from our American culture. For our culture, the Academy of Pediatrics recommends to breastfeed for at least 6 months with a goal of breastfeeding up to 1 year because of those added benefits. So once again, we have a stark difference between blacks and non-blacks, particularly Caucasian Americans, who at least for the first 6 months of life, have a low breastfeeding rate. And some of that has to do with the sexualization historically of Black communities within our American history. Certainly in slavery times, you know, the slaves would be wet nurses for the white children on the plantations. And so there's definitely historical seeds that have been planted for a very long time that has caused sort of this ingrained negative association with breastfeeding, which is a natural process, and sexualization of our human parts that can play a role in this discrepancy as well. But the other thing as well is that, once again, in our programs that assist people of need, until recently, there has been a big push by the formula companies to give formula, and unfortunately, when you have a lower income, that is going to be much more appealing, particularly if it's given for free. And so over the last 5 years particularly, there's been a larger push to help promote breastfeeding, to help promote breastfeeding education, and to help, again, increase or reduce that gap. So transitioning just a little bit, going from the womb to out of the womb, pediatric disparities. And I'm going to move a little bit quicker here since we're starting to run a little short on time. I want to hear your question. But same thing holds true as far as pediatric disparities. So asthma, huge diagnosis for the pediatric population as well as the adult. But you can see here from the Centers of Disease Control 2014, when looking at differences between asthma prevalence by age, sex, and ethnicity, again, significantly different. The Black population has a significantly higher likelihood to have asthma as compared to their white and, and you can see the Hispanic counterpart. So interestingly enough, Hispanics have a better rate than Caucasian population. So again, we've got that paradox. Again, the area, and this is obviously very true for asthma in particular, the environmental exposure definitely can cause increased risk of exacerbations. And then also having access to proper treatments. You know, inhalers are terribly expensive, and again, with Medicaid being the primary source of insurance for most populations of low income, that leads to problems as far as being able to control the asthma. Another huge disparity and another place where, once again, the U.S. is right on top is obesity. And so if you look at the rates of obesity in America compared to other developed countries, it's deplorable, actually. So there's a whole 10% extra next to our fellow Italians in the world as far as the rates of obesity. And this leads to, obviously, an environment that welcomes childhood obesity, which is becoming a huge problem now. You can see, again, the separation in age and between Blacks and non-Blacks as far as obesity is concerned. But where I want you to take a look at here in particular is that this is probably one of the few cases where this topic spans all races. So certainly as kids get older, particularly from in adolescence and going into college, yes, there's a small difference, but vastly, this is an issue that is touching everyone's life in the United States. And this plays a direct role in those food deserts that I made mention to in the beginning of the presentation. Okay, so we hear about all of these statistics. So what are some interventions that are already being implemented that can help reduce barriers? And the biggest one was passing the Affordable Care Act. And certainly we cannot be too quick to equate access to equity, which is what we kind of alluded to at the beginning of the presentation, but certainly being able to increase the amount of lives. Now we have 20 million Americans that have health insurance that did not have it previously. That's been a huge support in being able to reduce at least access to health care. Now, the back end to that and the other side of that coin is now we have more people insured, but we don't have enough people to see the patients that are insured. And that's why it's important to continue pressing forward and increasing Gme funding so that we can have more residency slots for primary care, particularly for family medicine, since most family doctors go into primary care setting, but certainly for our pediatric, our counterparts, that's important as well. And then the state child vaccine programs. And so it's becoming more and more in vogue for states to be able to have funding that is federal to be able to fund vaccines and have them free for all pediatric patients. And this has been able to drastically improve the vaccination rates in states. It's been shown as well that states that have vaccine registries also have an increased amount of completed vaccinations. And so California, being one of those states, started a vaccine registry a few years ago, and they're extrapolating data from that, but it's looking promising that the rates are increasing as far as the number of vaccinated children. And from the food side is being able to increase the affordability of healthy foods. And one of those ways is through the Women, Infant, and Children program, also known as WIC. It's one of the oldest programs that we have as far as social components are concerned. And now that you're seeing some states that are allowing payment with your WIC money to go to farmers markets and be able to access fresh produce with your WIC money in those kind of a setting. And then we talked about allowing interpreter services, which is a little bit different, however, still important for the reasons that I discussed. So what are some interventions that we can do, and what is our place as family physicians or primary care physicians in reducing disparities? And one thing that we talked about was increasing family medicine workforce. The reason I harp on family medicine is because of all the specialties, family medicine has consistently, at its native, been a specialty to serve communities, and it's been primary care focused. That was the whole purpose of the development of this particular specialty. And we see that particularly in internal medicine, most people do not go into primary care when they go into internal medicine. Same thing holds true, unfortunately, for pediatrics, although a little bit less. And so when we're looking to try to improve outcomes, we need to improve the workforce. We talked about interpreter services to be able to help with language or medical literacy and mandatory vaccination laws, and I'll talk about that briefly. Increasing diversity in the physician pool, and so again, I alluded to that earlier on. There is a disparate amount of African American, particularly African American males, going into medicine, and we're not quite sure why, but it's been shown in that patients are more likely to again, to find a connection and be able to be motivated to better their health care if they're able to see a doctor that looks like them. And so certainly everyone can help in various ways in underserved communities or for underserved populations. But it would behoove us to, again, continue to support minorities and underrepresented constituencies in our physician pool. And we talked about cultural competency and how integral that is within the context of a patient and understanding the context in which they live. So in California in 2015, last year, a law was passed that mandated vaccines, and it removed the exemption for personal beliefs from childhood vaccinations, and also it required a full childhood vaccination requirement in order to get into public schools or private daycare, or take part of any educationally funded programs. And so this was a huge move, and we've seen that in some of the other states that have signed on to similar laws, that the vaccination rate has increased. And again, this is for a public health standpoint, which is very important for reduction of communicable diseases. And so we talked about the role of primary care in reducing disparities. We treat disadvantaged communities. That's what we're here for. Family doctors treat people that need the health care, that need health care and exposure the most. We don't necessarily see that when we look at geographic data for nurse practitioners or physician assistants, who tend to go more into specialties and tend to stay in more urban settings. Although we do have great advanced practice nurses that work in our teams. We need to be trained to treat patients within their context. Just like Stephanie had mentioned, we need to be open to understanding patients' perspectives and improve quality of care and comprehensive delivery of care. And finally, I think what's super important is, as boots on the ground physicians and as students, it's important that legislators hear your voice. It's so interesting that many legislators are making decisions that have a trickle-down effect on at-risk communities, and they don't understand the consequences, unintended consequences of those laws that are passed. And so it's our jobs as medical students, as primary care physicians, to be able to express and share our story and the stories of our patients with the legislators, so that we can make sure that systemic disparities are lessened by enaction of law. Any questions?
All right, thank you so much, Dr. Ramas, for that presentation. If anyone has any questions, please go ahead and type it in either the chat box or the Q&A box at the bottom of the screen. I'll go ahead and start. My question for you is, actually today on our AMSA AdLib podcast, we heard from Dr. Wanda Filer on why she chose primary care as her practice. So same question for you. What motivated you to pursue primary care and family medicine?
Yeah, that's a great question. I myself am a first-generation Haitian American, and my whole exposure to medicine was due to me being very ill. I had terrible asthma growing up as a kid, and was in the hospital frequently. And I am a product of a lot of the services that I talked about in this presentation. And so it was natural for me to be able to touch people's lives and touch families as a central part of our society. And I wanted to be able to give back to the community that that invested in me.
That's amazing. Oh, we have a question.
Oh, yep. So Keenan, how can we advocate for social justice to be built into our medical school curriculum, particularly in places that might be resistant to changing the traditional model of education? That's a real great question, Keenan. So, you know, part of that is coming and getting involved in your academy, getting involved with family medicine interest group, and providing services to your fellow medical students. And so in Case Western, although it's very diverse, I was a part of the American Medical Student Association, SNMA, so it's for minorities. And what we did is we enacted a mentoring program, and then we actually made a symposium for talking about this medical disparities and why social justice is important for our minority communities. And it had a great response, so much so that we were able to get some publicity out of it. And what that did is that gave us the impetus to be able to go to the head of the school and have people sign petitions and let the head of the schools know that this is something that your constituents, your students, are interested in and want to hear more of.
All right. I have one more question. All right. What, in your opinion, I guess at a systemic level, how can the medical institution make primary care more attractive to students?
Yeah, I call it making family medicine sexy, bringing the sexy back to primary care. You know, we're doing it. And one of the reasons why I am so proud to be part of the Academy of Family Physicians is because we're in the face of legislators. We're there when there are tough questions to be asked, and we were part of the conversation in moving our payment system to be more favorable to primary care. And so, you know, changing how we get paid as family physicians, as boots to the ground primary care clinicians, I think that is a part of it. But then also getting rid of all the red tape. I mean, we've as a practice, as a medical society, we've been silent for so long. We've let other contenders, whether it's pharma, whether it's insurance, whether it's the government, tell us how we need to practice medicine and take care of patients. And I think what we're starting to see now is over the last 10 years, but certainly with our generation of physicians, we're not taking it anymore. You know, we want to be the voice for the patients, and we want to bring the joy back in medicine and the sanctity of the patient-physician relationship back into the examination room. And so my advice to you would be keep on being a squeaky wheel, keep on speaking for the voice of your patients, and when you do what's right and you do it loud enough and you do it persistently enough, people have to change. The other thing is that, you know, we're smart. You know, we as primary care physicians are smart folk, and what we're seeing now is we're starting to disrupt the system just enough so that we can start to get some more equilibrium for the benefit of our patients.
Awesome. The next question is related to that. So we have someone asking, where do you see family medicine practice in the next 10 years in terms of GME increasing the residency positions? What else has been done to further the family medicine to reach the community?
Great question. So I hear two questions. One is, where do I see essentially the government putting their money where their mouth is and making more family medicine positions to fill the gap? And then the secondary question was how, you know what? I can't remember the secondary question. What's the second part of that?
What else has been done so far to further family medicine to reach the community?
Oh, great, thanks. So to answer the first question, you know, again, we've been, as far as the academy is concerned, we've been advocating very heavily on the Hill to increase GME funding. But I think the key to increasing GME funding is this whole MACRA thing. And so MACRA is the new law that is changing the way that we as physicians or any provider is going to get paid for services. And this is changing the game field from a fee-for-service plane to now a value-based system. And although it's not perfect, what this does is it's shifting the pendulum back to, particularly for family physicians who have always shown that we provide comprehensive care and we provide it well and we reduce costs while we're doing it, while improving health. And so I think that once the government starts to continue to increase this value-based payment model, again, we're going to bring sexy back to family medicine, and we're going to demonstrate that there is value in the work that we do, and we're getting compensated for it. And as a result, that's going to create an economic demand for more family physicians and more spots. How are we getting into the communities now? So one of the things is we launched Health is Primary campaign, which was a kind of a PR way to kind of get the name of family medicine and primary care out into the public, and to help people understand that your family physician is going to be there to answer your hard questions, to walk with you during difficult situations, but also we're going to be a resource for you. And so that's been ongoing, and now we're starting to kind of evolve that Health is Primary campaign and evolve it into more, again, advocacy and being able to change that from a ground level up. The other thing that we're doing now is, as your academy, and I want you to know this, that the academy has made it part of its strategic objectives to increase and reduce disparities and to increase diversity within leadership and beyond. And so what that means is that at your academy, we have our hand to the pulse of what our members want and what they see as a need for the people that they care for. There are lots of programs that the Academy is doing, but then again, I want to reemphasize that as students as well, you can definitely impact the communities that you serve, even in medical school. I think that one of the most rewarding things that I did when I was in medical school was work in the free clinic, but then also be able to provide services for homeless communities in the community that we served while going to medical school. And, you know, it's not only a way to give back to the community, but it's more so a way to remind us as physicians why we got into the things that we got into. So, you know, so getting involved in your family medicine interest group, doing international work, but then also being able to give back on a local standpoint and able to coordinate programs in that way is important. And then as an academy, as a bigger umbrella, we definitely have a focus on diversity and being able to bring up leaders from historically underrepresented groups within the academy, but then also those people can go back to their communities on a state and local level to continue to pass that torch along. I hope that answered the question for you.
Oh, definitely. So with that, we've reached the hour. Thank you so much again, Dr. Ramas, for presenting. And thank you, everyone, for attending tonight's webinar. Please look into your local family medicine interest group and the American Academy of Family Physicians to get more involved in promoting primary care. And also stay tuned to National Primary Care Week. Tomorrow we will have a webinar at 7 p.m. on taking care of LGBT populations, and we'll hope to see you there. Thank you.
Thanks, everybody.